Good morning, good afternoon, good evening, wherever you are. It's my pleasure to have you here at our ReSViNET RSV webinar. Let me remind you of our vision to connect global expertise and leadership in order to decrease the global burden of RSV infection, with a mission to support performance of high-quality research, to improve knowledge of RSV epidemiology, and to develop safe and effective therapeutic and preventive interventions, with the goals to advocate and create awareness for RSV, to act as a focal point for effective partnerships with stakeholders, and to combine knowledge and capacity required to enhance the development of novel RSV therapeutics. I would like to remind you that separate from the webinars, we have developed the RSV Roadshow series. Together with the World Health Organization and PATH, we have 7 monthly educational web events that have the goal to increase awareness of RSV, prevention options, and implementation of strategies for informed decision-making. So we target decision makers, but we have noticed that a lot of people have enjoyed the first Roadshow series webinar 1 or 2 weeks ago. And at the right side of the slide, you can actually see the other webinars which are coming up, and feel free to join these events for free. You're very welcome. So today's webinar is about reconceptualizing RSV in adults to get ready to evaluate new treatment options. And before we give the floor to Chris Butler, I would like to remind you that we want to have an interaction at the end of the presentation. Please use the Q&A button at the side or the top of your screen and submit your questions during the meeting. That's very helpful for me so that I can organize them, read them, and prepare for the Q&A session in time. If you don't do that, it's still okay to ask them at the end of the presentation, but please consider using the Q&A chat during the meeting. Today's speaker is Chris Butler. He is a senior research fellow at the Trinity College, clinical director of primary care clinical trial unit, and co-director of NIHR in Oxford Health Technology Research Center. His main research focuses on improving the diagnosis and management of infections in the community to safely reduce antimicrobial resistance. And he has helped leading more than 30 RCTs in the community and played a key role in GRACE and PREPARE consortium research acute respiratory infections in Europe. What it doesn't say is that Chris was instrumental for some of the major RSV outpatient studies. The RESCUE study, one of the largest RSV community studies ever done, was performed by Chris. So Chris, we're very grateful and happy that you were willing to talk to us about RSV in the adult setting. And then I will now hand over to you to share your insights in RSV in older adults. Over.
Brilliant, Louis, and thanks a million for the opportunity to present at this occasion, and wonderful to have so many colleagues from around the world to share some thoughts about RSV and preparation for larger scale research, shall we say, into RSV interventions. So as Louis said, my talk is to really focus our minds on what people really think about RSV in older adults, and perhaps to effect a paradigm shift in the way we think about this illness. Because it's no secret that most people are very familiar with RSV as a common and sometimes very serious problem in younger children, and croup and so forth is a big problem. But we don't often think of this as a serious condition in older people. And this talk will help us think about reconceptualizing that position. Now, been thinking a lot about RSV recently because together with colleagues Joanne Wildebeest and David Lowe and Joseph Standing, we were able to produce an overview of RSV in older adults as part of the Lancet Respiratory series that got launched at the European Respiratory Society conference last week. And really what we did in this paper is to describe what is known about the epidemiology of RSV in older people, talk a little bit about vaccination, some emerging therapeutics, compare the burden of RSV both in health economic terms and in individual sickness terms a bit with flu, and make some conclusions. And my contribution was not only to take an overview, but also to sort of focus on the community aspects of it, because I'm a family doctor, general practitioner by background, and have worked clinically in infectious diseases settings in South Africa, Canada, and in South Wales in the UK, which are areas where RSV is a real problem amongst adults because there's high morbidity, lots of comorbidity, and as I'll show you in a minute, RSV tends to hit people hardest if they have illnesses like chronic obstructive airways disease or heart failure. And certainly where I was working in the South Wales coal mining valleys or former coal mining areas, there's lots of smoking, lots of lung damage, and RSV there was a very common trigger for things like acute exacerbations of chronic obstructive airways disease. And we know that the more people have these exacerbations, the more they are likely to deteriorate in their underlying health. Now, I was privileged to be part of the rescue study that Louis was a key leader of, and Kirsten was leading the output of that. And we added to 2 previous studies about looking at RSV from the bottom up, because mostly people look at a disease like this from the top of the pyramid, at the apex of the disease pyramid, those very few people who've been admitted to hospital. And here we looked at it from the asymptomatic older person in the community, and we followed them up every month over 2 winters, 2017, 18, and 18 and 19. And we recruited, well over 1,000 people. And each time they got an acute respiratory infection, we swabbed them and followed them up clinically. Now, what we found there is that if you look at it from the perspective of the free living, if you like, community older person, RSV is not a very, very serious illness for most people, and it affects only about between 3 and 7% of older adults each year. Mostly people manage it themselves. It's only around 17, 20, it's around a fifth that will go and consult their family doctor or general practitioner. And in this cohort, there were no hospital admissions. But look, it's not like flu that tends to, once you're better, you get better. RSV seemed to last longer. And from previous studies, the incidence is higher in those with the underlying lung conditions or heart failure, as I mentioned. And a much higher incidence, much higher hospitalization rate, and in fact, a significant number of those being hospitalized die. So if you're otherwise well, this is not such a big problem as an older adult. But if you've got the underlying problems, then you could be in for a rough ride. And so this brings me onto a really important point, which I'm going to be belaboring throughout the course of this talk. And that is, you've got to pick your patient who you are going to intervene with, be that vaccination, be that with a therapeutic agent. And there's a downside to treating everybody, because there's no drug on this planet that doesn't have side effects. And there's also the threat of antiviral resistance, which I'll come on to. So on the other hand, if you've got an effective treatment, you want to give it to the person who's going to benefit. So what this is telling us, this fantastic epidemiological, prospective, bottom-up study that starts with the well person. So it's not using what they call real-world evidence or mining routinely collected data. This is recruiting people and following them up, which is a very powerful research design. I mentioned that, people think of flu as being a disease which we need to worry about a whole lot more sometimes than RSV when it comes to older people. But actually, the epidemiology tells us something different. And of those admitted to hospital with the COPD and heart failure, in fact, we found in large cohort studies that RSV is more common, and that their risk of sequelae are greater with RSV sometimes than with flu. And, a year down the track after being admitted to hospital, their survival rate is slightly less, and they have a bit more comorbidity. And, it consumes as much healthcare resource as flu does. So the impact of flu and RSV are not that dissimilar. And yet we spend a lot of energy thinking about flu, planning for flu, vaccinating against flu, making therapeutics against flu. And to some extent, you could say RSV is a bit of an orphan viral illness when it comes to older adults. But as colleagues on this call will know, that is starting to change, because there are new vaccination. There are 2 licensed vaccines. I'm not going to talk about vaccines, but there are new RSV therapeutics coming down the line. And even if we had widespread vaccination with good coverage and effectiveness, we'd still need therapeutics. And, we know that is true in conditions like flu and COVID. There's still people who get very sick with it. And the thing about antivirals is that if they are going to impact upon viral replication or inclusion inside cells, we need to give them early on in the illness while that process is happening. And we don't want to give it to everybody, because, as I've mentioned, the study that Koos Korsten led and Louis led, conducted in the UK, Belgium, and the Netherlands, showed us that for most people, it doesn't need treatment. But if you pick your person right, who's going to benefit, you need to get it early. So that's the challenge of the use of antivirals for this illness. And then we can call that getting the intended use population right. And you've got to do your study in the people who you think might benefit from the drug before you roll it out, because there have been so many early phase studies in the world of infections, which perhaps show benefit given to an ideal population at the ideal time. But when you use it in the real world, we find the benefit has been overestimated. So there are different types of drugs. The RNA-dependent polymerase inhibitors, and then there are also drugs which inhibit inclusion into the cell. And I'm not going to go into that, just to make the point that drugs are being developed. There are others, and I wouldn't be surprised if before long there were drugs coming to market specifically for RSV, but there's absolutely no doubt that there will be broad spectrum antiviral agents coming to market as well, which will be covering RSV. So treatment options, who do we treat? We want to basically keep the drug away from those who don't benefit meaningfully and give it to those who will. And just to emphasize this family medicine perspective here, that the vast majority of illness is in the community that never comes to medical attention. And it's only a very tiny bit of ill people who land up in hospital, let alone in the ICUs. And it's early on where we can get the biggest bang for the buck when it comes to antiviral treatment. And this pyramid illustrates that. And you can see at the bottom of the pyramid, that's community use of drugs. And right at the top, tiny minority of people with RSV are going to be landing up in hospital, let alone in the ICU. But and you might say, yes, I'm a GP, a family doctor who is always moaning. But if you think about it, most of the research tends to happen at the deep end of the disease spectrum. Most of research funding goes into the sickest people, and studies of early prevention, applied clinical research are less well funded. I mean, rescue would be an exception that I referred to earlier. And certainly when it comes to RSV therapeutics, we're going to be needing to do trials, not only amongst the very sickest, but first and foremost amongst those who are early on in the illness course. And the reason for that is early on in the illness course, the illness is different. And this is a slide taken around COVID. And, a similar thing would be true perhaps of RSV to some extent. And, early on in the illness, you've got viral replication going on, and that's when you need an antiviral drug. When people have been sick for a long time with a viral infection, often there's an immune component, and intervening with that might give you a better payback than antiviral treatment, because the viral replication, unless you're dealing with somebody who's really immunocompromised, viral replication may not be the major problem. And hence, with the recovery trial for SARS-CoV-2, we find steroid being effective there. Now, you might start asking me, why on earth is this guy talking about penicillin when this is an RSV seminar? I'm wanting to take a kind of broad look at things and think about our history, because unless we learn from history, we could land ourselves up in the same hot water as before. And this is a cautionary tale about penicillin and where we went wrong with antibiotic use. And my main point is that we will need to not make the same mistakes that we did with antibiotics, that we do with those emerging antiviral drugs that I spoke of. And these are two pictures actually that I took myself. In the slide on the left, you can see a sort of a tower that's at St. Mary's Hospital, just near Paddington Station in London. And it's at the second floor window where Alexander Fleming, he left that window open when he went on holiday. And that's when the mold flew in the window and landed on his Petri dish. That led to his publication in, I think, 1929 about penicillin. And I pulled this out of the Lancet at that time. And it's quite interesting just to get the look and feel of these landmark papers, which, by the way, was completely ignored when it was first published. And this is an illustration from that. The white blob at the top is the actual mold that landed on his Petri dish. And these spots at the bottom are the colonies of bacteria that remain. But you can see an arc around the mold where the colonies of bacteria have died. And that got him thinking. And he did this experiment where on the left you can see a stripe of penicillin, and on the right you can see colonies of different bacteria that have died, and then E. coli, for example, being a gram-negative at the top there that wasn't killed by the penicillin. So amazing pictures of the original Petri dishes that, you know, I found fascinating to look at. Now, Fleming himself, in his Nobel Prize acceptance speech, he said, "The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with penicillin-resistant organisms." So he's saying something very important here, that if we take antimicrobials, and I'll include antivirals in this, and we don't use them wisely, and they either generate resistance or viruses become resistant to it, we don't use them wisely, we've got to take responsibility for the deaths of subsequent generations and those people who can't be treated anymore. Go back to the penicillin story. 10 years later, really, Chain and Flory in Oxford were looking for treatments for bacterial infections, and they found a paper by Fleming on lysozyme, and then they found another paper on the penicillin, and you can see Chain and Flory there, who started to work on penicillin, and they while there was a evacuation from Dunkirk to Britain in 1940, that very night they were doing an experiment with 8 animals, and half of these mice they gave penicillin to and the other half not. They were all infected with bacteria, and 4 out of 8 survived, the ones who got the penicillin. So that was it wasn't randomized, but I suppose they infected the they gave penicillin at random. So perhaps the first RCT in animals of penicillin. And these 3 people, Fleming, Flory, and Chain, got the Nobel Prize. And that's in the Science Museum down the road from where I am, the Nobel Prize, by the way. And people said, but what about this guy, Heatley, because he grew the mold? He should have got the Nobel Prize too. But I ask an additional question. What about Ethel Flory, who was Flory's wife, and Charles Fletcher, who were the doctors who started to do the clinical studies that identified how to give the penicillin, who to give it to, and so forth? Because without them, we wouldn't have had, without the proper clinical studies, we wouldn't have been able to use this drug. These are the clinical notes, actually, from that fellow Charles Fletcher, who was the junior doctor in the Radcliffe Infirmary down there, who tells the story of this policeman who was infected. They gave him penicillin. He got a whole lot better. They ran out of penicillin. They purified his urine, and then they gave him the penicillin taken from his urine, and he got improved, but then they ran out again and he died. It's a tragic story, and you can see this from their paper about when they were giving penicillin, his temperature comes down, and when they're not giving him penicillin, it goes up. And it's heartwarming, because I actually went over to the Bodleian Library and found letters that this fellow Charles Fletcher had given to his sister, and he describes the moving experience of giving penicillin to the first people that benefited, and the dramatic results. But he's a bit sort of humble. He talks about the clever people in the lab making this wonderful stuff, and he underestimates, I think, the importance of the people like him who were giving it to the patients and figuring out who should be getting it and who shouldn't. And, you know, that's an example of a little girl who was one of the first to get penicillin before and after. This paper is the first randomized controlled trial ever, a proper randomized controlled trial, and this is of streptomycin of Bradford Hill for TB. And this is the sort of model that we started on. And now I just want to talk about what I call assumption-based medicine. So that means you assume that if penicillin is good for somebody with pneumonia, it's going to be good for somebody with a cough. And if it's good for somebody with a cough, it's going to be good for somebody with a cold. And on the right, you can see Herman Goosen's famous correlational study, whereby they look at the outpatient use of penicillin by country. All those dots are a particular country, and they correlate it with the numbers of penicillin-resistant pneumococci isolates in hospitals. And those countries where they use a lot of penicillin, we find more resistance and so forth. So we know in correlational terms, at any rate, that there's a big problem when we overuse these drugs. And we overused these drugs before we did the clinical trials. It was only in the 1970s that those studies by Fletcher and Florey were done in the 1941-42. So it was sort of 30 years before we actually did the trials in the people who we were giving these drugs to in the intended use population. And it was trials like that Theo Verhey and from Louis' institution, University of Utrecht, and Nigel Stott and others, where we did these trials to show that actually for most people, antibiotics don't help when you have an acute illness of cough. Now, this 2x2 table is highly relevant to RSV therapeutics as it is to every other intervention, whereby we've got to keep the drug away, antimicrobial away from where there's low chance of benefit, and give it to those only where there's a good chance of benefit. So it's a simple 2x2 table, and people talk about personalized medicine, and this is really what personalized, individualized medicine is all about. It's all about determining who are in those 4 cells. So I'm going to move on to, again, conceptual thinking, and this goes to the COVID pandemic and figuring out which people should get antiviral drugs and which people shouldn't. And it goes back to a famous GP who worked near where I worked in the South Wales Valleys around, and he formulated this. His name was Julian Tudor Hart, and he formulated this inverse care law, which says that those people who are most in need of health care are often the ones least able to get it. And, you know, we can think of North-South in LMICs, but also within countries where the people most affected by infections and viral illnesses like RSV are the former coal miners living in a village like that one. And so illness is not equally distributed through, and RSV isn't, The people it's the most vulnerable who are most prone to get it and suffer with it. And they are the ones least likely to get health care. But they are also the ones who are most unlikely to get an opportunity to participate in research. And this was taken during the COVID pandemic. That was the view from my surgery in the Cynon Valley near Aberdeen in South Wales. And it got me thinking about this inverse research participation law, that those who have the most to offer research and benefit from the results are often the ones least likely to be given a chance to participate. And I led this trial called Panoramic, and it was about antivirals for COVID. And I'm using it just to illustrate what we could do for the new therapeutics that are coming down the line for RSV. Because as with COVID therapeutics, there were what we call efficacy, small-scale studies, which showed quite dramatic effects in unvaccinated populations early on in the pandemic. But there were puzzling results. And in this move-out trial of the drug molnupiravir for COVID, there were 1,400 unvaccinated participants, and not enough to figure out which subgroups might benefit and which might not. And funnily enough, they did an interim analysis, which showed a dramatic effect, and then a final analysis, and it looked the other way. So these small-scale studies can tell you, can the drug work? But we need larger scale studies also to find out if given at scale, who should get it and who will benefit the most. So we did this trial of molnupiravir for COVID, and also of Paxlovid, ritonavir, nirmatrelvir for COVID. And that built on a trial called the Principal Trial, where we evaluate 7 other drugs. And without going into too much detail, we were able, through direct engagement with the community and also through recruiting in general practices, to recruit over 40,000 people with acute COVID into these trials. And on one day, we randomized 500 people. And why I belabor this point is to illustrate that it is possible to do important trials at scale of novel antivirals to figure out, do they work overall? If so, is there subgroups that can be safely managed without, or safely, or who should benefit? And yeah, that's just the way that we were able to take research to every corner of the UK, where we could check eligibility remotely, look at people's clinical records remotely. And, of course, this was also happening in general practices, but we could courier medication to people's homes directly. And once we've done the efficacy trials, I think, of the new therapeutics, we need to be building on infrastructure like this to see the effectiveness of these approaches nationally and internationally. Another exciting development in trial and study design is the ability for self-testing. So without people, the last thing you want to do is to get somebody sick with COVID or horrible infectious disease to turn up at a research site. When they're sick in bed, if you can get them participating in the research, so because they're the ones you want to treat, and they are the ones who need to be in the study. So we can randomize them without them leaving their bed, and we can also test them with blood spots and with self swabs that they will post back. And here we did a trial of the virological impact of antivirals for COVID. And what we found here was very important. We found, yes, the antiviral, in this case molnupiravir, reduced the viral load. But on day 14, suddenly there was more virus in the group who had taken the molnupiravir. And we need to be checking impact on resistance and rebound every time we do trials of new antiviral agents. We also need to look at cost effectiveness, which is critically important because with these anti-COVID drugs, at that point, they were costing 500 euros a shot. So my final slide is to say lots of new exciting developments in the field of RSV therapeutics. Early phase trials happening, won't be long before there are later phase trials. But let's not make the same mistakes with antiviral drugs as we did with penicillin, because the reservoir of what we might call viral sensitivity doesn't belong to a manufacturer of a drug. It doesn't belong to a doctor, to an individual, or to a government. This is a common good which belongs to all of us. And we have a moral and ethical responsibility, as Alexander Fleming pointed out all those years ago with penicillin. We have a moral responsibility to look after that reservoir of antiviral sensitivity. So let's use what we've learned from the pandemic of COVID to do the trials properly to determine who shouldn't be treated in what we call the intended use population in the real world once we've done those efficacy studies. So thank you very much for listening, and hopefully I've stimulated some thought around the big picture stuff of making sure we do the trials. We don't operate on the basis of assumption-based medicine when it comes to emerging RSV therapeutics. Thank you very much.
Thank you very much, Chris, for educating us on for educating us on the development of antimicrobial resistance and our responsibilities as a society to prevent the development of resistance. So I'm sure there are questions from the audience. Many of them will be RSV related. So I will start with a few, and then others might join. You rightfully said, be sure that you test drugs in the population that you intend to use them for. So what are your thoughts on the use of RSV vaccines in adults? They are tested in all adults, but many of them will never be very sick. There doesn't seem to be a big risk of vaccine resistance for older adults. Of course, there is a cost effectiveness analysis involved. Everybody understands it. But what are your thoughts on prevention in the field of antimicrobial resistance development?
So, a very important question, because as I try to illustrate, targeting what you do, taking the economics of it into account is very important. Now, we won't get resistance, I don't think, from vaccination strategies. So that applies to targeting drugs or therapeutics. Now, do you vaccinate everybody? Because there'll always be some people without risk factors who do badly from RSV. And but figuring out the numbers needed to vaccinate to prevent somebody without risk factors from doing badly is an important first step. There's no question that those with underlying conditions such as heart failure, RSV, and so forth should be vaccinated. But how far out do you go from the deep end of multimorbidity to the shallow end? And those calculations, I think, are yet to be made. One might even say that actually vaccinating children might have the biggest impact on RSV in older adults, rather than vaccinating the older adults themselves. And I think, I'm not an expert on this epidemiology, but it's still being worked out, I think.
Thank you. So a question by Sarah is referring to when to treat. Viral loads often peak at 5 or 6 days after infection. but patients often present even after the peak of viral replication. And how do you treat timely, and how do you ensure that that is so? How much time do we have, and how do we ensure that we get in time?
Yeah, so a very important point, because as Sarah rightly points out, it's often at the peak of the viral load that people start becoming symptomatic. It could be that the viral replication carries on for longer in those with risk factors and those with a less functioning immune system. And there are those with severely damaged immune system where replication is just ongoing. So it could be that the window of opportunity is much greater in those who are frailer, older, and sicker. Now, one possibility is if we can get safe, cheap, and effective interventions that can be used early on, people who are older might have a broad spectrum antiviral drug that they keep themselves, that they could initiate at first sign of an illness. And, you know, there are nose sprays, for example, of different kinds that may prevent deterioration, and more that are in trials. So that kind of thing, which won't impact upon viral resistance, is one therapeutic maneuver. The other approach is that those who are at higher risk can be informed to consult early. For example, people with COPD, they often come in or start their rescue packs early. So it's those people with damaged lungs, for example, and heart failure, that can be primed to attend for care early on. So it's personal coaching as well, shall we say.
Do you see any room for early self-testing? So without any intervention, any healthcare that people at risk, such as the COPD population or the heart failure population, that they, in the winter season, when there are bad viruses like influenza, RSV, that they self-test, let's say within 24 hours, and then target the virus that makes them sick early on. Do you see any future for that approach?
At the moment, we have very good point of care diagnostics, but they or much improved point of care diagnostics that can give you, for example, RSV, flu, or COVID results very quickly. And these are easy to use devices, but they are expensive, and keeping them current with the right cartridges for a single person is probably not cost effective at this stage. But in a care home, for example, one might be able to have care home staff testing. In pharmacies, there's opportunities there, but etiological testing at this stage at home for individual patients isn't quite well enough developed, in my view. Now, there are other approaches to testing, such as, for example, looking at a biomarker such as CRP, where one can self-test now quite quickly. And you might say, if your C-reactive protein, which is a protein that goes up in your blood early on in infections, if that's very high, maybe you need to get seen or tested for an etiological agent quite quickly. But whereas if your CRP stays low, maybe you don't need an intervention.
So we studied the use of antibiotics in respiratory infections by various pathogens such as RSV. And what was striking was that a lot of the children with RSV were treated with antibiotics, but also a large part of the children were not treated with antibiotics. In adults, actually, it was different. Regardless of the presenting symptoms, they were all treated with antibiotics. An international study with a lot of sites, so it seemed to be sort of a generic concept that adults going to the doctor with respiratory symptoms, even in the middle of the viral season and symptoms were suggestive of a virus, they were still treated with antibiotics. Can you confirm that there's a high use of antibiotics, and why is that? Why is it different from children?
Yeah. So I think two things. Most children's lungs are in good condition and intact, and the clinical picture of acute viral respiratory illness in a child is quite distinct and relatively specific. So usually they've got a runny nose, and that's a very specific symptom. Whereas, and you can say, yeah, that it looks like a virus, and you can be more confident, shall we say, of not harming a child by withholding antibiotics. Now, that's a different trade-off in the adults. Now, you're absolutely right that depending on your place and time, between 50 and 75% of adults coming to general practice with an acute cough will get an antibiotic prescribed. But many of these people have previously had bad experiences with chest infections and felt they've benefited from antibiotics. So they've got high expectations. The doctors also have kind of, we need to move on. We've got 50 people in the waiting room. An antibiotic is sometimes quite a quick thing to give. But also, there's the fear of not treating somebody who goes on to have pneumonia and a serious illness. And these adults often are smokers with damaged lungs, with bacteria resident in their lungs. And so the chances, and particularly with chronic obstructive airways disease, you can't tell clinically if it's a virus or a virus that has damaged the lung lining and bacterial infection is now coming in there. So there's this worry of what we call secondary infection. And it's that, I think, fear of missing a serious bacterial infection or developing secondary infection after a virus that people will say, let's be safe rather than sorry. One thing that is happening more and more is for GPs to say to the patient, look, I'll give you some antibiotics so that in the middle of the night, if you're feeling terrible and getting worse, you've got it there. You don't have to come back. You can hold it. But just do me a favor, hang on, see if this will recover without the antibiotics. Because it's also true that people with COPD will also say, I will take antibiotics if I'm going to be in that block where I'm going to benefit, but I don't want to take them if I'm not going to benefit because I know that it's impacting upon the sensitivities of the bacteria in my lungs and my own microbiome. So public perceptions are changing, Louis.
Thanks. I like this strategy of prescribing but not yet using antibiotics, because this is sort of putting the decision with the patient as well. So thank you for bringing that up. Isaac is asking what your concerns are in terms of the development of escape variants to nirsevimab. I think that includes a question, do you think there is a role for nirsevimab in adults? Because at the moment, nirsevimab has been registered for infants, but do you see any role for nirsevimab in adults?
I'm not familiar with what clinical studies have been done so far, but
None of them.
Would say is, what we need to do before we do anything is to do an efficacy trial. That means in a well-defined population that we can monitor very closely, and we can take regular viral swabs over time, right up to day 14, and see what happens to the virology. We need to be able to know if we can culture virus throughout that time and so forth, so that before we even think about using a drug, we've got to do these comprehensive studies. Not only does it make people get better quicker, does it impact upon the viral resistance? Does it generate new unwanted variants? And once we're satisfied that we've got good data on those questions, then we can start thinking about who do we treat in the general population when they get RSV.
Right. Thank you. From my perspective, nirsevimab, because it is dosed at kilogram body weight, probably it's still early days to use it for any adult. It's just unaffordable. And the escape variant pressure, we will discuss in a webinar focusing on children rather than adults. So thank you, Isaac, but stay tuned. It will come back, and we are really passionate about evolution of RSV. I see a lot of people in the call with that interest. If there are no further questions, Chris, I would like to thank you on behalf of the ReSViNET Foundation. I also want to thank the audience for being here and joining this webinar. Thank you all. Have a great day and hope to see you soon.